Welcome to the deep dive. Today we're getting into something really specific, but pretty important in heart function. Second-degree atrioventricular block, specifically Mobitz type 2.
Right. So think of your heart's electrical system. You've got signals going from the top chambers, the atria, down to the bottom ones, the ventricles. Mobitz, this is basically a problem where some of those signals just, well, they don't make it through. They get blocked.
Exactly. And we're basing this discussion on a detailed medical text that focuses right on this type of heart block.
Yep.
Our aim today is to really break down Mobitz II, what it is, maybe what causes it, what could happen because of it, and, why this might matter to you.
And what makes Mobitz II stand out, I think, is how it behaves. It's not like some other blocks where the signal delay gets longer and longer before a beat is dropped.
Right.
With Mobitz II, it's more sudden. The beats that get through have a consistent timing, and then boom, a beat is just dropped without that prior warning, that's stretching out of the signal time.
Okay, so more like an abrupt interruption. We know it's a type of second-degree AV block. Let's just quickly refresh. What does second-degree mean in this context?
Second degree means it's a partial block. Some signals get through from the atria to the ventricles, but not all of them. There's an intermittent failure of communication, basically.
Got it. And Mobitz II's signature is that intermittent failure without the gradual slowdown.
Precisely. So on ECG, that's the heart tracing. You'll see these P waves, which are the intrathecal signals.
Wow.
And sometimes a P wave just won't be followed by a QRS complex, which is the ventricle beating, a skipped beat. But here's the key for Mobitz II for the beats that do conduct. The PR interval that time, from the start of the P wave to the start of the QRS, stays constant.
So it doesn't get progressively longer, like in the other type, Mobitz I.
Exactly. The PR interval might be normal or it might be prolonged, but it's consistent for every conducted beat right up until one is blocked.
So on the tracing, you'd see maybe PQRS, then just a P wave hanging there, then back to PQRS?
That's the idea. And because beats are being dropped, the overall heart rate, the ventricular rate, is usually slow. Bradycardic.
Okay.
You might also see fixed ratios, like maybe every second P wave is blocked, that's a 2.1 block, or every third one, a 3.1 block.
Right. And the source mentions high-grade block, too. What does that signify?
High grade, or sometimes called advanced second-degree block, is when you have two or more P waves in a row that get blocked. So multiple skipped beats back to back.
Okay. That sounds more serious.
It generally indicates a more significant conduction problem, yeah.
Now, why isn't the Mobitz classification type I versus type 2 used when you have these higher ratios, like 2.1 or 3.1?
Well, think about it. If you have a 2.1 block, you only ever see one conducted beat followed by one blocked beat.
Right.
You never get two conducted beats in a row.
No.
And because you need at least two consecutive conducted beats to see if the PR interval is lengthening.
You can't tell if it would have lengthened before the dropped beat.
Exactly. The pattern needed to differentiate Mobitz from Mobitz II just isn't there in a consistent 2.1 or higher block. So the classification isn't as helpful then.
Makes sense. You lose the defining characteristic.
Oh,
What about the QRS complexes themselves, the shape of the ventricular beats that do occur?
good point. They can look normal, narrow, but sometimes they can look wide or, abnormal in shape.
And does that tell us anything extra?
It can, yeah. A wide QRS complex in Mobitz II often suggests the problem might be lower down in the conduction system, maybe below the AV node, and it often indicates more extensive heart disease. It's generally seen as a bit more concerning.
Okay, so we've got the ECG picture, but what's actually malfunctioning in the heart's electricals? What's the pathophysiology here?
Well, first off, Mobitz II isn't common in animals with totally healthy hearts. It usually points to some underlying issue.
Right.
The fact that beats are just dropped like that can definitely affect how well the heart pumps blood, the hemodynamics. A significantly slow ventricular rate can be a real problem.
And you mentioned it can get worse.
Yes, that's a major concern with Mobitz II. It has a known tendency to progress, sometimes unpredictably, to complete AV block.
Where no signals get through.
Exactly. And that risk seems to be higher, especially if those wide QRS complexes are present. So catching Mobitz II is important because it can be a precursor to a more severe, potentially life-threatening rhythm.
And where is the actual block usually happening in Mobitz II?
Typically, the conduction delay or block in Mobitz II is located within the AV node itself.
Okay.
If you were to do specialized electrical studies, like a His bundle recording, you might see the signal travel okay through the first part of the node, but then it intermittently fails before reaching the next major pathway, the His bundle.
So a specific failure point, often within that central AV node area. Now, who tends to get this? Are certain systems affected, or are there genetic links?
Obviously, the cardiovascular system is ground zero, but if the heart rate gets too slow, other systems feel it.
Like the brain.
Absolutely. Poor blood flow can affect the central nervous system, leading to fainting or syncope. And muscles might get weak if they're not getting enough oxygen, so the musculoskeletal system is involved too.
Any known genetic factors?
The source material does mention potential heritability, particularly in pugs.
Interesting. Pugs specifically.
Yeah. And it's seen in both dogs and cats. Among dogs, besides pugs, breeds like American Cocker Spaniels, Dachshunds, Airedales, and Doberman Pinschers seem to be predisposed.
Okay, so certain breeds pop up more often.
And it tends to be more common in older animals. Age-related changes seem to play a role.
So if you have, say, an older dachshund showing odd signs, this might be on the list of possibilities. What kind of signs are we talking about? What might someone notice at home?
Well, sometimes nothing obvious, especially early on, but owners might report episodes of fainting or collapse.
Wow.
Or maybe just general weakness, or the animal seems really tired, lethargic. Sometimes the signs might be related to whatever underlying disease is actually causing the Mobitz II.
And what might a vet find during an exam?
They might notice weakness too. A really slow heart rate bradycardia is a common finding.
Palpable pauses.
Yeah, listening to the heart, you might hear or feel those pauses when a beat is dropped. Sometimes an extra heart sound, an S4 gallop, can be heard right when the block occurs.
Mm-hmm.
And if it's related to something like digoxin toxicity, that's a heart medication, you might also see signs like vomiting, not eating, maybe diarrhea.
Right, okay. So a range of possibilities. Let's dig into the causes then. We mentioned genetics in pugs and age-related changes. What else?
Increased vagal tone is a big one.
The brake pedal nerve.
Exactly. If the vagus nerve is overstimulated, maybe due to some other non-cardiac illness, it can slow conduction through the AV node and potentially cause block.
Okay, and the degenerative changes.
Yeah, in older animals, the specialized cells of the conduction system, like in the AV node or the pathways below it, can get replaced by fibrous tissue, like scar tissue or even fatty tissue. That disrupts the electrical flow.
Are medications often a culprit?
They certainly can be. We already mentioned digoxin. But others like beta blockers, calcium channel blockers, certain antiarrhythmics like propafenone, even some sedatives like alpha-2 agonists can potentially cause or worsen AV block.
So a careful medication history is crucial.
Absolutely. Even high doses of drugs like procainamide or quinidine could potentially trigger it.
What about problems within the heart muscle itself?
Definitely. Things that infiltrate the heart muscle, like tumors or amyloidosis,
Okay.
or inflammation, like endocarditis, especially if it affects the aortic valve area near the conduction system, or myocarditis from various causes, viral, bacterial, parasitic.
Lots of possibilities there.
Yeah. And cardiomyopathy, especially in cats, can be associated with it. Even chest trauma is listed as a potential cause.
And you mentioned something odd about atropine earlier.
Oh, right. It's a bit paradoxical. Atropine is usually used to increase heart rate by blocking the vagus nerve. But sometimes, especially when given intravenously, it can briefly cause or worsen AV block before it speeds things up.
Weird, huh? Very weird. Okay, so considering all these causes, are there general risk factors? Things that make Mobitz II more likely?
I'd say anything that significantly increases that vagal tone we talked about could be considered a risk factor, whether it's another disease process or even certain medical procedures.
Right. So moving on to diagnosis. How do vets figure out it's definitely Mobitz II and not something else?
Well, a key thing is distinguishing it, especially high-grade Mobitz II from complete heart block. The treatment and prognosis can differ.
Okay.
And also making sure the dropped beats aren't just non-conducted beats happening because the heart's electrical system is recovering from a fast rhythm, like in some tachycardias. That's different.
What about lab work, blood tests, etc.?
Super important. Checking electrolytes, especially potassium levels, low or high potassium, can mess with heart electrics.
Right.
A basic CBC and chemistry panel can point towards infection, inflammation, or other organ issues. If digoxin toxicity is suspected, checking levels is key.
And also,
In cats, checking thyroid levels, T4, because hyperthyroidism can affect the heart. Blood pressure measurement is important too. Maybe specific infectious disease testing depending on location and suspicion. Lyme, rickettsia, Chagas disease.
okay.
And if endocarditis is on the table, blood cultures.
And imaging. I assume an echocardiogram.
Definitely.
Mhm.
An echo the heart ultrasound is crucial to look for structural problems. Valve issues, muscle disease like cardiomyopathy, tumors, signs of infection.
You mentioned an atropine response test earlier, too. How does that fit in diagnostically?
Yeah, so you give a test dose of atropine and see if the AV conduction improves on a follow-up ECG.
What does that tell you?
If the block gets significantly better, it suggests high vagal tone is playing a big role in causing it. If it doesn't change much, the cause is likely more intrinsic to the conduction system itself, like those degenerative changes.
I see. Useful for sorting out the why. Is more advanced electrical testing ever needed?
Things like electrophysiologic studies where they put catheters inside the heart, usually not needed for a standard Mobitz II diagnosis from the surface ECG. But in really tricky or unclear cases, it could provide more definitive answers about exactly where the block is located within the conduction system.
Okay. What about if, sadly, an animal passes away? What might a pathologist see in the heart tissue itself?
It really depends on the underlying cause, of course. But if it was due to those age-related degenerative changes, they might see things like tiny mineral deposits, maybe some cartilage formation, and definitely increased fibrous tissue, like scarring right in the area of the AV node and bundle of his. Physical evidence of the system breaking down.
Okay, so we have a diagnosis. What's the treatment plan usually look like for Mobitz down?
Well, first, and this is important, if the animal has a reasonable heart rate and isn't showing any symptoms like fainting, you might not need specific treatment for the block itself. Yeah, but if they are symptomatic, fainting, weakness, collapse, then you absolutely need to intervene to increase the heart rate.
Wow.
The most critical thing, though, is always to try and find and treat the underlying cause, if possible. If it's drug-induced, stop the drug. If it's an infection, treat the infection.
Right. Target the root problem. What about supportive care?
Usually, intensive nursing isn't needed, but cage rest is a good idea for symptomatic animals just to reduce cardiac demand.
Diet changes?
Typically only if needed for an underlying condition, not specifically for the Mobitz II.
And what do owners need to understand?
Education is key. They need to grasp that treating the cause is paramount, and also that long-term medications to just speed up the heart in Mobitz X are often not very effective or sustainable.
Which leads to?
Surgery, potentially. For animals with persistent symptomatic Mobitz II, especially if it's likely to progress, implanting a permanent pacemaker is often the best long-term solution.
The pacemaker takes over the job.
Exactly. It ensures a reliable and adequate heart rate.
Okay, let's touch on medications again. Are there drugs used, even short-term?
Yes. If that atropine response test was positive, showing a vagal component, then short-term injectable atropine or glycopyrrolate can be used to boost the rate. For potential longer-term medical management in those atropine-responsive cases, oral drugs like propantholine or hyoscyamine might be tried, but again, their effectiveness can be limited.
What about emergencies? If the heart rate is dangerously low?
In an acute crisis, IV drugs like isoproterenol or dopamine might be used as a temporary measure to stimulate the heart rate while preparing for pacing or addressing the cause.
Are there meds that are definite no-nos?
Oh, absolutely. You want to avoid drugs that increase vagal tone like digoxin, certain cholinergic drugs.
The brake pedal activators.
Yep. And generally, be cautious with drugs that can further slow AV conduction or suppress the heart zone escape rhythm. So, many antiarrhythmics like beta blockers, calcium channel blockers, procainamide, quinidine, lidocaine need careful consideration or avoidance.
Any other precautions?
Keeping electrolytes balanced is important. Low potassium, hypokalemia, can worsen AV conduction problems, so that needs to be monitored and corrected.
Got it. So finally, looking ahead, what's the follow-up and prognosis like for Mobitz II?
Because of that risk of progression to complete heart block, frequent ECG monitoring is really recommended. You need to watch it closely.
Can it be prevented?
Unfortunately, since it's often tied to underlying disease or degeneration, there aren't really specific prevention strategies.
What are the potential long-term complications if it's not managed?
Chronic severe bradycardia can eventually lead to congestive heart failure, just from the heart working inefficiently for so long. And poor kidney perfusion is another risk.
And the overall outlook?
It's variable. It really hinges on the underlying cause and whether it can be treated. If it's due to something reversible, the prognosis might be good.
But if it's degenerative?
If it's those age-related degenerative changes, it often does progress to complete AV block. In those cases, the prognosis without a pacemaker is generally more guarded.
Okay, so wrapping this up then. Mobitz II AV block is this specific type of heart rhythm issue where electrical signals from the top to bottom chambers are intermittently blocked. but without that gradual warning sign seen in Mobitz II.
Right. And the key takeaway is its potential to progress to complete heart block, which makes finding and addressing the underlying cause really critical.
It really underscores how precise the heart's electrical system normally is.
It does. When you see this kind of abrupt failure, it's often a sign that something more significant is going on beneath the surface. It's not just a minor glitch, usually.
Yeah, it's a fascinating look at how a disruption in one part of a complex system like the heart's wiring can have pretty serious consequences. Makes you think about, similar vulnerabilities in other complex systems, whether biological or even technological. Lots of interconnected parts where one failure point can matter a great deal.
A good final thought.
Indeed. Well, thanks for joining us for this deep dive today.